Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by High Tech Answers and Healthcare Now Radio, part of the Answers Media Network, and is sponsored by the law offices of Myrick O'Connell. Now here is your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Mason Beard, Chief Solutions Officer at Philips Wellcentive. Welcome, Mason.
Hey, Matt.
Well, it's great to have you on today. But before we really start diving into our main focus, which I think will probably end up being value-based care, can you just give everyone a little bit of an introduction as to who you are and what you do?
Absolutely. Again, my name is Mason Beard. I am the Chief Solutions Officer here at Philips Wellcentive, and my primary job responsibilities are marketing and product strategy. And I've been in healthcare and HIT specifically for 16 years now, and have been focused mainly on the technology side, technology innovation, and then transitioning kind of the technology into a marketing and positioning message specifically around population health management.
Were you always interested in healthcare, or did that kind of just happen inadvertently?
Yeah, I mean, out of undergrad, I started school as an occupational therapist and really was drawn to healthcare. And then after a few years, quickly felt the pull of the IT world or health information technology, and wanted a career that blended both sides of really the healthcare services as well as the technology aspect. And started that back in 2000 with a home care software company called Patient Care Technologies, which was part of Meditech, which is incidentally one of the oldest software companies in the nation.
No, that's actually pretty interesting. I don't think I'd ever heard that fact before.
Older than Microsoft.
So, and I think you said your focus now is on population health. So when did you start focusing in that area?
Yeah, so population health management was a really focus of mine starting in 2005. And admittedly, it wasn't even a word. It wasn't a concept like we know it today. And we started, I helped found a company called Wellcentive, and we basically started the company that was a all-disease, all-payer registry, which evolved to a concept of population health management. But that company started, and the ideas for that company started when we saw an opportunity where some commercial payers like Blue Cross Blue Shield, Cigna, Humana, et cetera, were starting to pay physicians based on quality on top of some of the fee-for-service revenue. So if a particular provider would be able to say that or prove that of the diabetic patients they saw, they are keeping the hemoglobin A1C in check, or any male patient they had that was over 40, they made sure they had a PSA test, they would pay them on top of that fee-for-service code. And, you know, the other co-founder and I saw an opportunity that if this is the way that reimbursement is going, if quality does matter, then this would be something that would be pretty cool and an untapped market. And we also noticed that the EMR companies weren't really serving this purpose. You know, they were built for a whole different infrastructure, if you will, for kind of billing and scheduling. So the old all patient, all payer, all disease registry became a household term called population health management. I think that kind of came around 2010.
So if you said you were starting to see this transition back in 2005, it would sound like that was probably one of the first arguable reoccurrences of that kind of concept after the HMO movement in the early 90s.
Absolutely. You know, the HMO movement, it was almost population health, but they forgot the patient. You know, they did a really great job at the cost perspective and arguably on the quality, but the whole patient experience was just kind of thrown out the window. And in 2005, it was really a pay for performance infrastructure. We weren't into accountable care. We weren't into upside or downside risk arrangements. it was really just P for P dollars on top of fee for service.
The statement you just made about, with the HMOs, that they forgot about the patient experience and kind of forgot about the patient. Were you seeing that in that early stage of 2005, which I think, based on kind of how you ended your last statement, maybe not? And if you didn't see it back then, when did you start seeing the patient really considered within this construct?
Yeah, that's a great question. I think around 08, 09, a lot of people were talking about the triple aim, which has now evolved to the quadruple aim, which I could touch on. But the triple aim really was saying that we need to focus on cost containment, quality attainment, and patient experience at the same time. And I think the triple aim came from basically dissatisfaction with the HMO, where, as I said, they nailed the cost containment, but really forgot the patient experience. And as we evolved to the triple aim and more of the population health management concepts, I really saw that, and it's been an invigorating ride ever since '05. I really saw that as the first win-win in healthcare economics, where the patient wins, the healthcare payer wins, and the provider wins if the infrastructure is set up correctly. And other businesses have figured this out way before U.S. healthcare has. I jokingly do this when I talk to people. I said, how many people in this audience have a pet, cat or dog? And everybody raises their hand. And I say, how many people here think that their cat or dog get more proactive care and reminders from their vet than you do from your PCP? And it always gets a laugh, and everybody raises their hand. But it really is a snapshot of your interaction with your PCP provider or any healthcare provider, and the triple aim, I feel like, corrects that, and it catches healthcare up to other industries, that understand the retail experience.
So I guess, can you provide any specific examples in terms of how that is actually bringing the patient more into it? Because, just trying to think about a lot of the discussions that I end up seeing, it still has that big message or feeling that the patient is not necessarily fully involved in the process, and kind of, just to what you were saying about, just simple reminders. You have a great example with the vet, because I have a dog, and we get reminders like clockwork when our dog is ready for something, but I still don't think I get those same type of reminders from my primary care provider, who happens to work in an organization that has a lot of risk-based contracts, and it would make sense to be having that kind of outreach.
So, yeah, and you hit the nail on the head. I'm not talking about patient engagement, and I'm not talking yet about activation. So let's put that in kind of the future. I'm saying that as a consumer, I would feel more like a partner with my healthcare provider if I had a letter, or if I had a phone call that said, hey, we reviewed your records and your labs indicate that you need to come in and get checked. Or that, we know that you're a diabetic patient. Maybe we've looked at the fact that you're taking certain medications, and we notice that you haven't been in to see your PCP. So we'd like to see you. I as a consumer, would feel that I'm being cared for, versus I think the system today is more sick care. Is if I have a problem, I come to you, and we don't have a relationship, and you don't have a historical record or longitudinal record, versus the vet example is they know you so well, they're going to remind you when you need a certain vaccine and everything else. And what is that going to translate, Matt, with you and that vet? You're going to stay with that vet because you feel like you're cared for, and there's more of a partnership there.
Yeah, no, I think that's a fair point and helpful to draw that distinction. So kind of as you said, that you see I think you call it patient activation, or patient engagement is still down the road. When do you see those components really getting brought into the system?
Yeah, no, that's, patient. So, the terminology went from the all payer registries to, we were talking about population health management, to then what's the new frontier. Patient engagement, and I'm going to throw in the word activation, has been something that's talked about for the last 2 years as the next kind of holy grail. And I really think that as an industry, the health information technology industry has a lot to learn from the retail experience industry. And we won't learn to activate patients until we can create a Amazon type experience where it's easy to access my provider network. I can see cost and price transparency much like Amazon, when I can go and see I shop for the most amount of stars, right, and the lowest cost. Healthcare is the opposite, but ordering something on my phone through Amazon Prime is an engaging experience, and it's easy and inviting. I don't think healthcare has figured that out yet, and there's a bunch of obstacles, but activating a patient such that they receive care in a virtual environment or they receive care outside of the walls of a hospital in a consumer-friendly experience, I think that's the holy grail, and that's when you're going to move from engaging patients, which is, sending a letter, make a phone call, having a care manager call you, to activating and having me engaged in an experience where I can access care and also engage in my own health care in a way that these retail people have already figured out. If I don't log in to Amazon or to Facebook or to other apps, they send notifications to remind me to come back. And we just haven't reached that in healthcare.
Right. So I guess maybe before diving into, maybe some of your thoughts or concepts in terms of how to actually create that experience you were just describing, let's touch on what we actually have in place today, which I suspect is probably a significant development beyond what you saw when you first got into the field or got into this particular kind of population health management field, despite the name difference in 2005.
Yeah, I mean, what's happening and how the industry has evolved is more and more populations have gone from unmanaged to managed, meaning that healthcare payers and providers are creating and kind of creating contracts around a specified list of patients or membership, and they're being treated in a proactive way. I think we've moved the needle in incenting the providers to put systems in place to call patients about care when they see utilization patterns happen outside of the PCP office. I see incentives being placed for provider behavior to order the right tests, to look for alternatives around virtual care. And I think that the patient experience over time, if you're in a managed population, it's a better experience. And I think that it used to be, there was pockets in the East Coast, pockets in the West Coast, of value-based care arrangements with the payers and the health systems that kind of created these populations and incented providers to change the workflow and to provide care differently. I see that nationwide now. There's still some pockets of flyover states where you don't have it, but primarily there's value-based care arrangements all over the nation, and I think you're seeing the transformation of provider offices, and that rolls up to IDNs performing differently and accessing patients differently. And I think we've come a long way from the old volume-based business where there was no incentives to track patients that used the ER too much or to not send out those reminder letters and engage patients.
And for those of you just joining, I'm talking with Mason Beard from Philips Wellcentive about the growth of value-based care. And kind of as you're just talking about that, you're seeing more nationwide adoption of value-based care models and where you have incentives and agreements between the payers and the providers. Do you feel like we're starting to reach kind of a critical threshold? Because I feel like when I'm reading reports, it's still suggesting that a sufficient number or a sufficient amount of the patient population in particular practices isn't at a high enough threshold where it tips in favor of the financial reward for doing so is necessarily big enough to support all the kind of the expansion of services that should be going along with this model.
Yeah, I mean, I hear that a lot, and you have to look at the definitions of risk-bearing agreements to understand just how many patients or members have some form of risk. So without getting in that definition, I can tell you two other perspectives on that argument. One is a pure fee-for-service argument for implementing population health management. If you have a command of your data and you understand the population that you serve, you will find patients that need to come in for needed care. So if I have a command of my data, I can find everybody that is over a certain age that needs a flu shot. And if I implement a pop health strategy, I have a call campaign, I have care managers call them, I have letters that go out. I'm bringing those patients in for their flu shot or preventive care like mammograms, PSA tests, et cetera. And what I'm doing is generating an uplift in fee-for-service volume, but at the same time, I'm improving my quality scores that help me negotiate better rates with payers on a fee-for-service level. So I didn't mention risk-bearing contracts at all, but I did mention implementing or leveraging population health management strategies in a fee-for-service world. Another perspective that we need to take into account when we're trying to measure kind of the popularity of pop health and value-based care is market share. The health systems that are progressive out there are looking at leveraging pop health strategies as a way to increase market share and improve access and patient experience for the members they serve so they can continue to grow. And the health systems out there that are a volume play and that aren't kind of implementing these strategies or aren't getting aggressive with any value-based care arrangements with payers, they're going to see market share continue to decline. So it's a pure market and access play versus anything about value-based care.
No, and those are very fair arguments. And kind of as you said, you can make very compelling cases to convince practices why, no matter what world they're living in, this is just a good business sense and will help ensure that their continued existence within their market.
Right. And Matt, just one more that just hit me is if you talk to the C-suite of any health system and say, well, where does contracting directly with employers fall in your strategic plan? And everybody would say, oh, absolutely, it's on our roadmap. You can't do that unless you can point to the value of the care you're delivering, which is cost over quality, and show that their product is better than the competing health system. That's pop health, right? I mean, we didn't talk about value-based care, but the idea that you would go straight to an employer and you're going to market a product that is based on value, which is cost over quality, you have to have some pop health infrastructure to do that.
Yeah, no, arguably, I mean, that's maybe one of the more advanced forms of it, because now you've cut out the arguable middleman of the insurance company, and you have, as you said, the provider and the employer directly negotiating, and the provider's taking all the risk to a large degree of saying, we're going to provide this high quality service at this price, and they have to be able to determine that the price that they agree to is something that covers the cost of them providing the service, and then like any good business, gives them a margin on top.
Right. Absolutely.
So, and kind of thinking about that perspective, I know we were kind of all the arguments you were just making were just obviously generally applicable reasons in terms of why it's a good idea to go down these roads. But thinking about just risk-based contracting, which is a phrase you had been throwing in there, what are the different forms of it, and are providers actually taking on real risk, or is it more that they're taking on potential just upside benefit?
No, it's definitely upside and downside. So in the traditional, or kind of what I was historically speaking about, pay for performance, that is, if I hit certain quality thresholds with, for instance, my HbA1c values for my diabetic population, my preventive care, screenings, et cetera, I'll get an incentive, which is upside. In an ACO arrangement or a commercial plan arrangement where if you don't hit certain cost thresholds, let's say generic med usage, ER utilization, et cetera, then it's downside or cost. You don't hit that and they're going to take money back. So there's both sorts or types depending on the payer and the arrangement you have. Anything from, I was thinking about plans that have a Partners in Performance program, which is at upside, a PCMH program, which is upside, or some of the ACO arrangements, which is upside and downside.
So in terms of having both the upside and downside, do you see downside playing a larger role with private arrangements, or is it, I know it's a part of the Medicare ACO models, but it feels like not many of the participants have chosen tracks where there is kind of significant downside risk.
Yeah, I see that is primarily with the Medicare and ACO arrangements, but the advanced health systems that basically have a command and control center where they actually can have an eye on cost and utilization, and they've transformed their offices, they're more than willing to take on the downside risk with the commercial plans because they have their house in order.
Yeah, no, I think that's a good point. It's I get the benefit from being based in Massachusetts. I think I get to see a larger share of those types of organizations because they've been pushed in that direction, I think, more quickly here than arguably in some other parts of the country.
Yeah, absolutely. Yeah, that goes back to that. There are pockets of the U.S. that have traditionally been more forward thinking, and Mass certainly is. Some of the innovative programs that I've seen out of the payers there too.
Yeah, having gone down the rabbit hole of the current situation, I do want to be able to get back to the picture that you're painting of what the future could look like, and what could be necessary in terms of getting to that next stage of as you were describing, the patient activation and the real patient engagement. So do you have thoughts in terms of what it would take to create I think you were saying the Amazon style interface?
Yeah, I mean, I think we have some hurdles to get through. I think physician buy-in, physician engagement is critical to any behavior change because, really many times they own the relationship with the member or patient. And to solve that, I really feel strongly that we need to have higher data quality. The term interoperability is thrown out around a lot, and that's not solving the problem. That's passing files back and forth. But physicians have to have confidence in the data. People have to be more willing to share the data from the payer side and the EMRs, and the quality of that has to increase. So that's kind of a current hurdle. Then on the consumer side, and the kind of the holy grail of patient activation, I believe the systems need to mature in such a way that I can shop and my health system or a vendor I choose to work with can show me a retail experience that I can see price transparency. I can access my health network, and I also can, we can provision, a vendor can provision or a health system can provision very targeted programs about my disease state, about the impactability of my demographic based on data that I share. And I think that there's some gaming concepts that are going to come into play, like gamification. Lord knows, I look at my kids and the way they play video games and Fortnite, and how these companies have mastered engagement and keeping them on these things. I think that's going to happen in a healthcare realm as well. We'll see gamification in some of the user experiences for healthcare.
Yeah, although at least from my perspective, I think one of the most important pieces that you were just mentioning is the drive to collaboration, where you have to get really all the components truly working together and recognizing that if they all get on the same page, then everyone's going to come out a winner. But if you still try to operate from a siloed perspective, instead of creating some winners and some losers, you're probably going to end up creating just people who aren't succeeding because it's not going to coincide with where the system is going.
Absolutely. This when I mentioned earlier the win-win, where you're shifting risk, but it really is the patient experience is a winner, the health system and the payer is a winner. That takes collaboration. and it truly has to be frictionless. Your interaction with all three of those parties to make this work.
So what incentives do you think will be needed to really drive that 3+ sided collaboration?
Well, the payer incentive has been known for many years. They're looking at cost containment. I think from the patient perspective, I think there's been some hit or miss initiatives out there, but I think from a rewards perspective, engaging people into activating their own health, whether that's an Amazon gift card or, like I said, some gamification where they're engaging with an app. But then also, as a CMO once told me, how do you herd cats? You move the food bowl. And he was specifically talking about provider behavior. I think for providers to engage, you have to continue to have programs where they get a share of the savings or they get upside incentives for providing care that's different. So I think all three need to be incented, but just different tactics for each.
Right. It really sounds like it comes down to a redistribution, and I think it is fair to say a realignment of the industry from how it has operated for a significant period of time.
Right. Absolutely.
So, believe it or not, we are already very close to the end of our time. So, I'm going to try and close out with one final broad question for you to be able to offer some speculating. But kind of where do you see the industry being in terms of the progression that we've been talking about over the next couple of years?
Yeah, I think you're going to still continue to see M&A activity and consolidation in the healthcare provider space. I think that there's going to be a separation between the winners and the losers in metropolitan areas. I think you're going to have some poor performing hospitals are going to go out of business because of market share. I believe that you're going to see payers and retail, like the announcements you've seen probably in the news lately, you're going to see more of that because from a retail experience, with your big retailers and payers, they're looking at trying to engage the consumer in a new, innovative way. You're going to see more of that consolidation in the future.
Yeah, no, it'll definitely be interesting to see. And as I had just hinted at, believe it or not, we are out of time. So I would like to thank my guest, Mason Beard, for a great conversation today.
Thank you, Matt. It was a pleasure.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.